Okay, so it is really my honor to next introduce my co-host of this meeting, who is Dr. Chip Schooley, and he's going to talk to us today about COVID interactions with other viruses. Dr. Schooley is a longstanding HIV researcher, educator, and clinician in HIV medicine. He is a professor at UCSD in the Division of Infectious Diseases. And after a very long history as the head of the Division of head of the Division of Infectious Disease at the University of Colorado. He was at one point the chair of our AIDS clinical trials group funded by NIAID, and has been chair of multiple study sections, DHHS task forces, and in 2005 joined UCSD and is really well known not only for all his research, but as a recently, I think, retiring, but editor of the in-chief of clinical infectious diseases. So thank you so much for talking to us about COVID-19 and other viruses.
Thanks very much, Monica. It's great to be with everybody today on this foggy day in San Diego, which is unusual, but I'm looking forward to having a chance to spend the rest of the day with you. Today, I'm going to talk primarily about the interactions between HIV and SARS-CoV-2, but I'll also make a few comments about how the virus is interacting with other viruses in our virome, because it really has had a big impact on many aspects of what we do. Am I in the correct mode here?
Yes, Dr. Schooley, if you can switch the displays.
I was asking. Okay,
yeah,
terrific.
Perfect.
All right. So here are my disclosures. And I will move now to talk about learning objectives, or to talk about the potential biological and clinical interactions between SARS-CoV-2 and HIV, and talk about some of the uses of COVID drugs and vaccines in the HIV-infected population. With most of this actually coming in the next talk from Raj Gandhi, who will be talking about the use of these agents in the general population, which parallels very much the HIV-infected population. We've all been on this roller coaster of COVID in the US and around the world. We've now unfortunately had 750,000 deaths from COVID in the US alone, and over 5 million around the world. I'll be talking today in kind of two sections. First, about the interactions between, in terms of the HIV-COVID interactions, the interactions at the individual level, and then I'll talk about some of the societal impacts that COVID has had that have complicated care for people with HIV infection and other medical illnesses that we all care for. So there are a lot of reasons that one might think that SARS-CoV-2 would be a real issue from the standpoint of HIV, including immunodeficiency and other things, which we'll talk about. And I'll start by saying it's surprising in many ways that although there is some increased morbidity and mortality, it's not any more striking than it actually has turned out to be. The reasons that one might think about COVID being a particular problem in HIV-infected people, when you think about the pathogenesis of SARS-CoV-2 infection, we have an early period of virus-host interaction in which SARS-CoV-2 turns off the innate immune response, grows rapidly in the lungs, and then quickly explodes into the upper respiratory tree, and as the adaptive immune response tries to gain control, which it does in most people, and others, regulation of the immune response leads to a progressive downhill course of inflammation in the lungs and systemically, and death. HIV is characterized by both a cellular immune deficiency, particularly in people with advanced disease, and immune activation and dysregulation, even in people with well-controlled HIV infection on long-standing antiretroviral therapy. And these two pathogenic interactions could well have spelled quite a bit of mischief in terms of what happens clinically. But let's see what actually happens clinically. And first address whether people with HIV are they at risk for more severe outcomes if they become infected with SARS-CoV-2? There have been a number of studies that have tried to look at this, and I'll start by saying the studies are very complex to put your arms around because they are done at different times in different populations with different underlying comorbidities and different SARS-CoV-2 strains circulating in the community at the time. So I'll try to illustrate a few of these studies to give you a sense of kind of where I think the needle has finally fallen. One of the first studies to look at this was one that was performed in New York that took advantage of two large databases that the New York City Department of Health had assembled. One was their HIV surveillance registry, and the other was their surveillance system for COVID-19 that they linked in the early explosion of COVID in New York City, where they had 200,000 COVID cases, and of these, about 2,000 were people living with HIV. And you can see a couple of things when you begin to look at the subsets of these populations. People who had HIV, as you might expect, were more likely to be male than those who did not have HIV. You can see again that the patients with both HIV and with COVID, and particularly with HIV, were disproportionately represented by those in disadvantaged groups economically and in people with underlying medical conditions compared to people who had COVID without HIV. These sorts of imbalances make it complicated, and as I mentioned before, in trying to sort out morbidity and mortality across the two compartments. In this study, which was very well done in terms of capturing the data, another very strong feature of it was that the two populations were studied contemporaneously. In other words, they gathered all of this data at the same time so that there aren't differences in time between the people with HIV and coronavirus and people with coronavirus alone. To make a long story short, there was no evidence that people with HIV were more likely to become infected with SARS-CoV-2 in New York during this first wave. About 1.5% of the New York population became infected with COVID, and only 1% of the HIV infected population in New York City developed COVID. However, when one looks at what happens to those people who were HIV infected and got COVID as well, they were more likely to end up in the hospital. They were more likely to end up in the ICU. And they were more likely to die of their infection in this particular run through. Now, one thing that's, as I've already said, is that although there was no more COVID in people with HIV, more people became ill, but there were many more underlying disease conditions in people with HIV than without HIV, which was one of the things that seemed to be driving this, because the same risk factors that we see in other diseases in other patient populations also drove morbidity in the HIV COVID co-infected population. That was further underscored in another very nice study done shortly thereafter. It was a registry of patients that was sponsored by the University of Missouri, and in which the Infectious Disease Society played a role. People with who had were caring for patients with HIV who developed COVID were asked to participate and provide information and case report forms about these patients that they were caring for. And they gathered almost 300 people with HIV and COVID. This study did not have an HIV uninfected population to compare, and it was clearly one that was overrepresented by people in the hospital just because of the nature of the sampling approach. But what you can see is that in general, there was the same sorts of trends that one sees in terms of age were seen in this population of patients, with more older patients in the HIV population getting into more trouble in terms of hospitalization, And it really isn't until you get to when you start looking at CD4 cell counts, you can see that there also is a trend that people with lower CD4 cell counts were more likely to be hospitalized than those with higher CD4 cell counts. Because the large population of people in the US were virally suppressed, there really was only a modest difference here. And in other populations, this is less evident as well. But in people with more advanced HIV infection may be more likely to get into more trouble than people with less advanced HIV infection. But again, one might expect a coalescence of risk factors in groups of people who are having trouble connecting with the healthcare system to get suppressed with HIV infection and to become result in a rising CD4 cell count. This is another bit of data from that same study, again, making the point about the CD4 cells, and also making the point that these underlying cofactors that play a role in the other populations that we talk about also are very important here. And again, you can see the same thing is true with the more comorbidities you accumulate, the more likely you are to get into trouble with 3.5-fold greater chance of being hospitalized if you've got 3 or more comorbidities. And then looking at severe outcome, and this is ICU admission, intubation or death, the same trends are evident as well. And as well as in the non-HIV infected populations, hypertension, chronic lung disease were seen here. And as in the other analyses, low CD4 cell count played a role as well. And these are just the Kaplan-Meier plots that go with that. Again, you can see here that when you look at ICU survival, free survival, people with higher CD4 cell counts do better. And in terms of overall survival, there's a trend in the same direction. When one looks at the population level, again, moving back away from just case reports of mainly hospitalized patients, this is a large study reported in Lancet HIV from the UK, looking at a primary care database in people over the age of 18 that was then segregated into those with and without HIV, with COVID-related death being the major endpoint. And they were able to look at 17 million people on this database. And I guess thanks in part to Bojo, 27,000 of them were HIV infected and also were studied for COVID. When one looks at adjustment for age and sex and index of multiple deprivation, in other words, connectivity to the healthcare system and other societal factors, ethnicity and comorbidities, some of the things that we're talking about begin to shake out. So looking at crude risk of death, there really is, things are really pretty well even. But when you start looking at some of these comorbidities, you can see that the hazard ratio in the HIV infected population rises, and there are more of these cofactors in the HIV infected population than the uninfected population. And if you look at this population, the hazard ratio of death in the HIV infected population over this period of time compared to the non-infected non-HIV infected population in the UK in these primary care practices, you can see that there was a disproportionate increase of about 50% among the HIV infected population, taking all comers. And finally, we'll looking at one of the resource limited settings, this one, a study in South Africa that looked at people who were cared for in the public sector, in other words, the South African healthcare system, who had been seen at least once since 2017. Looking at those with HIV, with COVID, and those hospitalized with COVID, and then calculating the mortality ratios for COVID with and without HIV, the data they generated were quite interesting as well. They were able to look at 3 million patients, and of those, 20,000 had COVID and with 600 deaths. And HIV was associated with COVID mortality with about a twofold increase compared to non-HIV infected populations. And it was similar in the South African study across all strata of viral loads and immunosuppression, except at the extreme. Another factor that was also noted was that people with prior tuberculosis compared to those without prior tuberculosis had a further increase in the hazard ratio. And when one looked at the overall association with death, again, as I said, depending on how you factor in the comorbidities, about a twofold increase in the HIV infected population. And here again is a plot that shows some of the risk factors in the HIV infected population. This is the HIV population I mentioned in general, a little bit over twofold. Prior tuberculosis, a bad prognostic feature in this. And again, age across the board in the South African experience as well, and gender. Now, to finish this issue with CD4 cell counts, again in South Africa, there was a trend toward a increased morbidity and mortality as the CD4 cell count declined. So although many of the large population-based studies in which many people with HIV infection are well controlled in the West don't show big changes in morbidity and mortality, in places where there are a larger number of people with lower CD4 cell counts, we begin to see differences in how people do when they are infected with SARS-CoV-2. So to summarize, there's no evidence that people with HIV are more likely to get COVID when COVID rolls through the population. But they are more likely to disproportionately share societal risks that may place them at risk for getting COVID in terms of jobs and living conditions. There is some evidence that even after adjusting for underlying risk factors, HIV adds to the morbidity of COVID. There are more risk factors in general in people with HIV pushing toward severe COVID than in the general population, non-HIV infected population. And there is a trend as your CD4 cell count declines to get into more trouble. Now let's ask about vaccination. I'll be quick here because the data are emerging, and I think what's more important than whether they respond in an equivalent fashion is that they respond generally reasonably well, and there is no reason at all for anyone with HIV infection not to be vaccinated. Many of the studies that have been done suffer from problems with comparability of which vaccines were given to the HIV infected population analyzed compared to the non-HIV infected population, age discrepancies and so forth. And I'm not going to spend a lot of time running through each of them, but I'll just show you some data, top line data from two of them. This is a preprint from Sabrina Brum in British Columbia, looking at about 250 people with HIV infection and what are called controls, but these are really healthcare workers who were vaccinated actually with a different vaccine. But to make a long story short, if you look at things that were that detracted from response, one was if they were vaccinated with an adenovirus vaccine compared to mRNA vaccine, as we'll discuss later. Chronic underlying conditions resulted in lower responsivity to vaccination, as did age, as in the HIV uninfected population. But when you look at the overall population, red is after dose 1 and blue is after dose 2, even across the whole CD4 cell spectrum. By the time you boost, you begin to get reasonably good titers in most people who are HIV infected. So that what one can say is that it's very worth vaccinating people with HIV infection when one looks at these results immunologically. Unfortunately, we don't have good long-term studies about how this translates into protection from disease in the HIV infected population per se, but these types of immune responses do in the general population. the overall population, including HIV and HIV uninfected populations, do make a difference in terms of morbidity and mortality. And in the same study, in a different study from Hopkins with a very small number, this one actually well controlled between the HIV infected and uninfected population. I just want to make one point about cellular immunity. People with HIV infection have slightly lower cellular responses, but it's just as broad. And these responses are really quite important, I think, in decreasing morbidity and mortality. The most important point I want to make today about vaccines, though, is whether you are HIV infected or not, coronavirus vaccine immunity and coronavirus immunity in general is fleeting. This is a study published yesterday in Science that looked at 750,000 US veterans and looked at the longevity of protection with the 3 vaccines used in the US. And you can see that, as we've seen in other studies, decay of protection from infection with the Janssen vaccine is fastest, followed by the Pfizer vaccine, followed by the Moderna vaccine. I'm not going to go into other data from this study, but I encourage you to look at this paper. It's a very nice paper. The same trends are seen in terms of each of these vaccines with death and SARS-CoV morbidity. And when one looks at the death rate in these veterans, even those who have breakthrough infections have an impact on their death rate. So please pay close attention to both vaccinating and maintaining immunity in your HIV infected patients. So to close this section about the individual, prevention is just as essential in the HIV infected population as the uninfected population. There is a modest effect on humoral responses as measured in the lab. Boosting is essential. Treatment, people with HIV are more likely to get into trouble, moderately so. And therapeutic intervention should be similar in the 2 populations, realizing that people with HIV infection have different levels of immunodeficiency, and lower thresholds should be considered when one thinks about therapeutic interventions to prevent hospitalizations and death with monoclonal antibodies, and as the oral agents roll out, likely there as well. Now let's turn to society and then make a couple of points. These are data from China from a paper published last month, just to make the point that the whole world saw a shutdown of social interactions in response to the COVID outbreak. China was particularly effective in closing things down. And what that's led to is less opportunity for other pathogens to be passed around. These are data from that Chinese experience, just showing you the number of respiratory diseases reported in China during 2020. And you can see that everything from mumps to flu was heavily affected during the periods of the biggest shutdown. They began to rise when things were opened up, and then as things shut down again, same experience. Tuberculosis was not as heavily affected, perhaps because people with TB also include people who are reactivating. It's important to emphasize that with the healthcare system less accessible, these case rates may not completely reflect what's going on in the population because you have to be surveilled to be counted. But it does make the point that with less social interaction, respiratory viruses and other viruses, in this case, and pathogens, in this case, even syphilis and GC in China, we're seeing less frequently with less social interaction. What the rebound is going to be as these viruses come back, as we begin to interact, is going to be something we have to pay attention to and think about the timeout our immune system has had from influenza, respiratory syncytial virus, metapneumovirus, and realize that as we unmask and interact, we may have a rebound in morbidity and mortality, as have been seen in some places like Australia with a couple of these diseases. Now, what about the impact of the social disruption caused by HIV, by COVID in the HIV infected population? This is a very nice study done in the Africa Coast cohort by the Walter Reed group that was published in CID earlier this year. And what you can see is that in their cohort, which is followed very closely, they were able to maintain very good ART adherence. And in fact, as they moved from the early phase to the late phase of COVID, viral suppression was extremely good, even though visit adherence was impacted. So in the midst of substantial disruption, one can continue to maintain good AIDS care. They noticed that, particularly in the early phases of this, there was food insecurity. And that's one of the things that continues to be a problem in resource-limited settings. The secondary effects of COVID are substantial. This is a nice study from the WHO that looked at across a large number of countries what kinds of things happened to the healthcare system. And just as in the US, the healthcare system was impacted by insufficient staff. There was a lot of concern about coming to the hospital. People who had conditions that would normally come in a steady stream didn't come because they were afraid to come, or the clinics were canceled. Financial difficulties were a problem for people in terms of getting health care. Some people couldn't even travel. So the healthcare system was very heavily impacted across the board in terms of the COVID epidemic, and it'll be some time before much of this resets. We in the West were very lucky in terms of having access to telehealth and other activities. This just shows how much telehealth was introduced in the Western, in the resourced countries compared to places where things were more limited. And this has been one of the things that has certainly helped our HIV infected population in the US continue to get the kind of care that we like to see them receive. So I'll close now and just say that COVID's had a substantial impact on people living with HIV around the world, and indeed on all of us. It doesn't increase the risk of becoming infected, but those who do get infected have a higher morbidity and mortality from COVID than those who were not the HIV infected population. And things that drive morbidity and mortality in the non-infected HIV infected population do in the HIV infected population as well. The approach to using vaccines and therapeutics should mirror it, remembering that there are more people in the HIV infected population who are immunocompromised. Vaccination is essential. The lockdowns and isolation have reduced non-COVID infections of multiple key types and have led to mental health problems and isolation, which I didn't get into today, but we shouldn't be overlooking as people begin to come back into society. Healthcare systems were disrupted around the world, particularly in places where they were on the edge to begin with. But the global healthcare workforce itself has done a stupendous job, in my view, of working in extremely difficult circumstances over the last year and a half. And as I mentioned earlier, disadvantaged populations are disproportionately affected both by HIV and SARS-CoV-2. Health equity remains an essential goal for all of us. And as a prelude to the next talk, I want to also recommend you a very nice editorial in CID written by Raj Gandhi and his colleague, Virginia Triant, that talks about the intersection between these two pandemics. Thanks very much. And I have enjoyed very much being with you today and look forward to spending the rest of the time. Thanks. Back to Monica.
Great, thank you so much. That was a phenomenal overview of really these colliding epidemics of HIV and COVID. And we have a couple of questions coming in. One is that you went over that really and showed us the review article that comorbidities are higher in people living with HIV that can predispose to more severe COVID. What can you say specifically about the impact of smoking as a risk factor among people living with HIV with higher rates in that population?
That's a great question. And smoking in COVID has been also something that's been all over the map. There was even one study that showed that smoking protected you now from COVID. And I kind of cynically thought that it may just be because people smoke hack and carry on may just be missing coming in for mild COVID, not getting diagnosed. I think people who have had enough tobacco use to have lung damage and COPD, there's good evidence they get into trouble. Whether people who have smoked and don't have clear evidence of lung damage have more difficulty, I think is a lot harder to know. I would not endorse smoking to find out, but the evidence about smoking per se is still not really as strong as it might be.
Great, thank you. And then why do you postulate that the deaths, sort of per capita have been lower from COVID-19 in Africa than in the US?
The part of it, I think, is ascertainment. In resource settings, most people who get severely ill get to the hospital, and most people who become severely ill in the hospital have a diagnosis or two attached to them. And in a lot of resource limited settings, hospitals were overwhelmed and turned people away. People died at home, may not have been recorded. And I think that really, it's very hard to know at a population level what the real death rate is. The other thing that I think is really critical is that COVID had a lot of, and still is having a lot of secondary impacts on our healthcare system. People who have other conditions that need healthcare are not getting it, and some of them are dying from it. A colleague of mine had a close family member in his mid-40s who was unfortunately in the middle of a big COVID-related surge in one of our states where vaccination is not emphasized. He had a ERCP and died in 2 academic hospitals because he couldn't get the care he needed because of the COVID surge. And so even here, people are dying from non-COVID related conditions because we're letting our hospitals and our healthcare systems get overwhelmed, which is a crime with the vaccines now being available. In resource limited settings, this is even more of the case. And I think that the COVID related deaths, both directly and indirectly from missed healthcare opportunities, food insecurity, and other things, still haven't been tabulated.
And I think that's a great point, and it also could be different comorbidities in populations like obesity and other COPD and cardiovascular disease, and just differing comorbidities that predispose to severe COVID. Is there any population data on the potential effect of HIV protease inhibitors against SARS-CoV-2 infection, with the knowledge that a SARS-CoV-2 protease inhibitor data was just released for this morning from Pfizer about specifically targeting SARS-CoV-2, but HIV PIs on SARS-CoV-2?
There were some early data from Spain that I found hard to interpret. Again, channeling bias and other things playing a role in it. The HIV protease inhibitors per se don't have anti-coronavirus activity at levels one achieves in vivo clinically. There have been some studies that have looked at ritonavir and other, primarily ritonavir, in its activity in SARS-CoV-2 and MERS, and even those studies showed were interpreted as showing perhaps some impact, but they were small, and I think there was enough wiggle room in terms of how they were done to fund it, because other things were given some concurrently. It's very hard to interpret them. So I think that people who are on HIV and protease inhibitors should certainly stay on them if they're working, but they shouldn't count on them protecting them from COVID and skip vaccination, testing, and other things that we want all the rest of us to do in the COVID days. The the protease inhibitor data from that we heard about this morning is really exciting, and it's very worth as a teaser staying on till after the news for Raj's talk.
Yeah, it's interesting because that protease inhibitor is boosted with ritonavir in the same way that we're so used to with our HIV drug.
I actually don't think any Abbott drug is not boosted with ritonavir, is it?
That's it. Yeah, very good point. At one point, we were very reliant. So we've one of the attendees, Dr. Uman said, we've had a few patients come in post-COVID with depressed CD4 counts. And if you see that after an acute COVID illness, have you thought about like resuming prophylaxis, for example, with CD4 counts less than 200? And how long do you wait before repeating the CD4 because of these post-COVID effects?
Well, there are a couple of things that can take it out. One is COVID itself, with lymphopenia from that. Another thing is a lot of people get corticosteroids as part of their COVID management. And there aren't many things that are as effective as in clearing out CD4 cells as dexamethasone. And there have been patients who have been dexamethasonized for COVID who've developed pneumocystis and other HIV-related complications. So I think it's very reasonable in those patients, if you're worried about them, to reinstitute prophylaxis for PJP in the context of their low CD4 cell counts. I don't know what the trajectory of recovery is because I haven't seen cohorts followed with repetitive systematic CD4 cell counts to look at the kinetics. So I would just take a functional approach and probably check every month or so in your patients and adjust your prophylaxis accordingly.
Yeah, that really makes sense. And it was interesting, your discussion of the post-COVID HIV vaccination, COVID vaccination among people living with HIV, because we did a separate analysis that showed the same findings of reduced antibodies, but actually ended up looking at T cells, and T cell responses to the COVID-19 vaccines were intact if you had a high enough CD4 count. Okay, that is actually any other questions or comments from our participants?
I see a question in the chat box from Dr. Benson who wants to ask a question. I don't think she should, but go ahead and let her do
it. Okay, let me.
Somebody needs to unmute me. So thank you for allowing me to ask a question.
I see.
I was just wondering if in your survey of all of the recent data from resource limiting settings, I've seen some data in the tuberculosis literature that people with HIV co-infection have worse TB and COVID when those two things occur together, and that there may be an interaction pathogenetically between COVID and mycobacteria, or it may just be that both are respiratory infections that affect disease. And I'm wondering if you had, there was a big surveillance study from South Africa that showed that the mortality rate for people with HIV and TB during the COVID pandemic was actually higher than in the non-COVID population. So I'm wondering if you found any more data related to the pathogenesis of COVID and TB as a co-infection.
Not directly. I have to say, I think, and you know this more than me, I think people underestimate the long-term impact of TB on the lung, and even in people who've been treated and recover. I mean, we're used to thinking about, I had pneumococcal pneumonia, got treated and got better, and not worrying about longer-term impacts. And I think a combination of probably fibrosis, immune activation, immune modulation, that lasts much longer and is much more persistent in people who have or who have had TB, and COVID layered on top of that certainly can set things off in the wrong direction. Could COVID, with its own immune dysregulation, essentially reactivate TB or enable TB to pick back up in people who were reasonably controlled before COVID came along? Absolutely. And if you start giving people who are having respiratory distress dexamethasone, TB, I'm sure, be quite happy with that. So I think there are a lot of things that relate to both the pulmonary physiology, pulmonary immune responsiveness, and COVID-related therapeutics that could certainly cause people with TB to have a worse outcome than people without. That's a great question.
I was thinking in the context of the suppression of interferon axis by COVID and SARS-CoV-2, and that's a particularly important axis in the pathogenesis of tuberculosis. And so that may be one way that they can interact in a bad way.
No, it's a very good point. COVID is one of the things that Dr. Benson's alluding to, is that one of the tricks of SARS-CoV-2 over SARS-CoV is that it very actively turns off the innate immune response, in particular the interferon axis, in the first couple of days of infection, which is how it replicates to such high levels and why it is so highly transmissible before people are symptomatic. The symptoms people get are when their innate immune response catches up, and they begin to become febrile and feel the inflammation. Anything that turns off that axis or prevents the host from being able to activate that axis is going to give COVID a head start on the adaptive immune response. So I think that's a very good way to think about it.
And as you indicated, there's so much impact on other diseases. It's not just, there's a general increase in TB, mortality for the first time in a decade. I've just reported over the last couple of months. So yeah, it's been a really difficult time for our fields of HIV, malaria, tuberculosis, all of those outcomes. Okay, well, thank you so much. And I actually will turn it over to you, Chip, to introduce Dr. Raj Gandhi.